Welcome everybody to another Road to Wellness webinar. Today's topic is Takayasu's arteritis, and we have some great panelists with us here today that are going to help us to understand it and help us go through some questions that we have. And I'd like to start by introducing our panelists. I'll start by introducing myself. I'm Kathy Olevsky, and I'm the Road to Wellness webinar host for the Vasculitis Foundation. I'm a patient living with MPA vasculitis. I was diagnosed in 2008, and I've been in remission since, I've been in remission for 7 years off treatment. So I have a deep desire to learn more about every type of vasculitis there is, and that's what we're going to do today. So I'd like to introduce our panelists today. We have Dr. Caitlin Quinn, who received her medical degree from New York Medical College. She completed her internal medicine residency training and rheumatology fellowship training at Georgetown University Hospital. She subsequently completed a 2-year vasculitis clinical research consortium and the Vasculitis Foundation Fellowship within NIAMS Vasculitis Translational Research Program, where she focused on vasculitis from a clinical and research perspective. Dr. Quinn is board certified in internal medicine and rheumatology. Today, we also have Dr. Peter Grayson. He's board certified in internal medicine and rheumatology. He completed his undergraduate degree from Brown University, his medical degree from the Medical University of South Carolina, and has a master's in science from Boston University. He served as chief resident in internal medicine at Boston Medical Center and completed an additional 2-year vasculitis fellowship with the Vasculitis Clinical Research Consortium. He serves as the associate program director for the NIAMS Rheumatology Fellowship Program, and he's a recipient of numerous teaching awards. And today we also have a special guest, Lauren Bacchetti, who was diagnosed with Takayasu's arteritis in 2014 while living in Montana. And after a 3-year battle with the disease, she underwent carotid artery bypass surgery at the Mayo Clinic after doctors discovered that she only had 15% blood flow to her brain. Now, after a successful surgery, Lauren enjoys her second chance at life, taking every opportunity to educate and support other vasculitis patients. So welcome, everybody. We appreciate you being here today. And I think with that, we're going to actually turn it over to Dr. Quinn and let her teach us a little bit about Takayasu's.
Hello, everyone. I'm excited to be discussing Takayasu's arteritis with you today. And I'm going to focus this discussion on 7 key facts to know about Takayasu's arteritis. And these facts include the cause of Takayasu's arteritis remains unknown. The arteries that are affected differ from person to person. Symptoms can be from either active disease or damage. Lab tests are not perfect. Imaging of the blood vessels can be helpful. Surgery may not always be necessary, and we have limited data available on pregnancy outcomes. So I'm going to go through each of these 7 key facts in more detail on the following slide. So our first key fact is that the cause of Takayasu's arteritis remains unknown. It's likely multifactorial with genetic factors and environmental factors and other factors playing a role, but we really don't know what causes it. It's more common in women compared to men with a 9-to-1 female to male ratio. And age of onset is typically between 20 to 30 years of age, although younger people, including children, can be affected. It's not something that typically runs in families or is hereditary, and it's not something we usually see passed down from generation to generation. The next key fact to know is that the arteries involved can differ from person to person, and the arteries that are affected may ultimately determine what symptoms someone may have. This image here is a magnetic resonance angiogram, or MRA, of the whole body, and you can see the aorta, which is the main blood vessel running through the chest and abdomen in white here, branching into arteries in the legs, and branching into arteries in the arms and head and neck region. So if someone has involvement of the arteries supplying blood to the head and neck and brain, they may experience headaches, lightheadedness, or visual changes. If the arteries supplying blood flow to the arms are affected, then someone may experience arm pain or heaviness, particularly with repetitive use, things like washing hair in the shower or putting clothes in the dryer. And over time, low or absent blood pressures in the arm may develop. If the arteries supplying blood flow to the kidneys, which are shown here, are affected, then blood pressure may become elevated. And if the arteries supplying blood flow to the intestine are affected, then abdominal pain after eating may occur. And finally, if the arteries supplying blood flow to the legs are affected, people may experience leg pain with walking. But the point of this is that the arteries that are involved differ from person to person, and so not everyone is going to have the same symptoms. Our next key fact is that symptoms can be from either active disease or a result of prior vascular damage. So during periods of active vasculitis, inflammation of the aorta and its branches occurs. And over time, if this inflammation is not controlled, the arteries can become damaged. And this can be in one of two main ways. The arteries can become stenotic or narrowed, where it's difficult for blood to flow through, or the arteries can develop enlargement or aneurysm. Symptoms that occur as a result of damaged arteries may not always improve or reverse with treatment. So in some cases, people may have ongoing symptoms, but they are from damage and not a sign that the disease is active. Lab tests in Takayasu's arteritis are not perfect. C-reactive protein levels, or CRP levels, and erythrocyte sedimentation rate levels, or also known as ESR or SED rate, are blood tests that are often checked. If they are elevated, it may be a sign that there's ongoing inflammation. And so in some cases, they can be helpful to assess whether the disease is active or not. However, there are several pitfalls to keep in mind about these lab tests. They are non-specific markers and can be elevated from other causes as well, particularly from infections. So if someone with Takayasu's arteritis has an infection, like a urinary tract infection, these lab tests may be elevated, but it's because of the infection and not necessarily due to active Takayasu's arteritis. These lab tests can also be normal when the disease is active. And we see this in about 25 to 30% of patients that lab tests look great, there's no elevation, and yet the disease is active. And the lab test can be affected by certain medications, particularly a medication called tocilizumab, which is a biologic treatment sometimes used to treat Takayasu's arteritis. The way this medication works, CRP levels often become undetectable, and so it's not reliable to use CRP to monitor in patients who are taking tocilizumab. Our next key fact is that imaging of the blood vessels can be helpful, and this includes the use of angiography. These images here are representative images of magnetic resonance angiography, or MRAs, but computed tomography angiography, or CTAs, can also be used and give comparable information. The white arrows in these images are pointing out areas where the blood vessels have been damaged. And if we look at this image on the far left, you can see the aorta, which is the main blood vessel, looks okay and then becomes irregular and narrowed here. This image shows damage to an artery going to the right arm. And this image here shows damage to the arteries going to the arm, as well as damage in the abdomen. And this is another example of damage to an artery going to the arm. Another type of imaging test that can be helpful in Takayasu's arteritis are FDG PET scans. And this is a type of nuclear medicine study where a radiolabeled tracer called FDG is injected. And this is essentially radiolabeled sugar water. And so we're looking for this radio tracer to go to areas of metabolic activity in the body. And in cancer or oncology settings, we're looking for metabolic activity in tumors. Whereas in Takayasu's arteritis, we're looking for metabolic activity in the blood vessels. And if someone has a lot of metabolic activity in the blood vessels, it suggests there's ongoing inflammation there. In this image, green indicates a moderate amount of activity, and red indicates a severe amount of activity. And we see activity throughout the aorta and the arteries going to the arms and head and neck. This is another example of a PET scan from a patient with Takayasu's arteritis. And here we see a lot of activity in the arteries going to the head and neck. These are the carotid arteries. And this is a sign that there's ongoing inflammation in these arteries. We can also see the same thing in another view here. There's also activity in the abdominal portion of the aorta to suggest ongoing active vasculitis affecting that area, which we also see in this image here. The next key fact is that surgical intervention may not always be necessary, and this is largely in part due to the development of collateral arteries over time. So in this MRA image here, where the white arrows are pointing, we see this new collateral artery has formed over time. This person has a blockage in the artery going to the arm, and so blood is unable to flow through, and so over time, this new artery has formed around the blockage. And you can think of this like being in your car in a traffic jam where you're unable to get to your destination, so you may take an alternate route. That's essentially what these collateral arteries are doing. There are specific cases where surgery may be needed, and we can't wait for these collateral arteries to form, which can sometimes take years and years. So someone who has extensive damage to the neck arteries with poor blood flow to the brain, if there's damage to the heart arteries or heart valves, if there's damage to the kidney arteries and blood pressure becomes very elevated and can't be controlled with medications alone, if someone has an aneurysm that's continuing to enlarge and is at risk for rupturing, or if someone has a lack of blood flow to a limb, either the arms or legs, impairing function and quality of life. Whenever possible, surgery should not be performed if the disease is active, and it's best to do when it's controlled and quiet. We have limited data about pregnancy outcomes in Takayasu's arteritis. To minimize potential complications, it's best to plan for pregnancy during a time when Takayasu's arteritis is well controlled. It's important to involve a multidisciplinary team of doctors, including a maternal fetal medicine specialist, and certain medications that are used to treat Takayasu's arteritis can't be used in pregnancy, so medications may need to be stopped or adjusted with your doctors. The Vasculitis Pregnancy Registry through the Vasculitis Patient Powered Research Network is currently collecting information about how vasculitis, including Takayasu's arteritis, affects pregnancy outcomes. So if you're thinking about becoming pregnant or currently pregnant, this link includes more information about that registry. So to summarize, we discussed 7 key facts to know about Takayasu's arteritis. We don't know what causes it. The arteries that are affected differ from person to person. Symptoms can be from either active disease or damage. Lab tests and imaging tests are not perfect, but can be helpful. Surgery is not always necessary, and we have a lot to learn about pregnancy outcomes in Takayasu's arteritis. There are several groups actively doing research in Takayasu's arteritis, including our group at the National Institutes of Health, and I've included key members of our study team and contact information here. My contact, Dr. Peter Grayson, and Elaine Novakovich, who is our research nurse.
Well, thank you so much for that information that you presented, Dr. Quinn. I think that helped me understand a lot about Takayasu's, and I understand now that you and Dr. Grayson are going to talk a little bit with Lauren about her experience with Takayasu. So if one of you would like to take over and start with that, that would be great.
So Lauren, thank you, first of all, for spending time with us and for sharing your story. I think probably we'd start by just having you share your story. What was your pathway to diagnosis, and what happened over the course of time with this disease?
Absolutely. Thank you both so much for your time and taking the opportunity to listen to my story and letting me educate others. So my story, I feel I was very lucky as far as diagnosis goes. I think I only started experiencing symptoms for about a year before I was officially diagnosed. So probably around 2013, I started noticing I was getting ocular migraines a little bit more frequently. I'd never gotten those before. The biggest symptom that I had was I was tired all the time. And now when I say I was tired, I used to get up early, no problem, stay up late, no problem. I was sleeping 12 plus hours a day, plus napping on my lunch break. And that was just not like me. I couldn't function. And I had no idea why. It was just very bizarre. Finally, what led me to go into a specific specialist, was I noticed when I would look up, I had a pain in my throat. And so I decided to start with an ENT. They decided to do, actually, I don't know the technical term for it, but a swallow test where I swallow while they image to see the path that the fluid takes. And they did notice a slight deviation in my neck. Or in my throat technically, but in my neck area. And so they ordered an ultrasound of my neck. And I was very fortunate that the radiologist doing the read recognized right away that I had already had some blockage and recognized that it was Takayasu's. And so I was put in contact with a doctor. As I mentioned, I was living in Montana at the time. I was put in contact with a rheumatologist who had, just a small handful of Takayasu's patients. But that's where I was told initially what Takayasu's was. And, some of the things that I had already, had experienced. He did recognize right away then that the artery to my left arm was already almost completely occluded. So they could not get a pulse on my left arm. And I never took my pulse much, just as a regular old person. And so it was kind of a shock to me that the pulse was super faint. And the right one had already started going at that point as well. And so that was all in 2014. And again, I consider myself pretty lucky, as I know a lot of other people with Takayasu's experience a number of other symptoms and really struggle to find that diagnosis. So fast forward a few years, I moved back to Minnesota. I was in contact with two very incredible doctors, my rheumatologist in the cities, and then a rheumatologist down at Mayo Clinic. And just after a few years, and I experienced some really stressful situations that unfortunately I think amplified the effects of my disease, I started experiencing severe pain in my carotid arteries. And eventually, after a long series of imaging and just trial and error with medication, unfortunately, it was found that I had 15% blood flow to my brain. At that point, I was experiencing dizziness whenever I stood up. Driving, I probably shouldn't have been driving, because anytime I'd turn my neck, my eyes would get I don't even know how to describe it. It just was a very weird sensation in the eyes. And so I did end up undergoing carotid artery bypass surgery in 2017. And so I know others are lucky where it doesn't have to get to that point, but mine did require some intervention, surgical intervention. And then on top of that, during all of this, they did find out that I have an aortic arch aneurysm, or my arch is aneurysmed. This could be due to a number of things. They also found out I had a bicuspid aortic arch valve during all this. I like to joke that I won the lottery of lucky diseases, or rare diseases. And so I will have to have additional surgical intervention in the future to replace my aortic arch as well, just due to, I think, the inflammation and the valve as well. So I know that was a lot of information, but that's just kind of my story, what's led me up to this point.
It sounds like you've told your story many times before, because that was a beautiful, succinct version.
Oh, thank you. Thank you.
I think maybe Dr. Quinn and I will react to elements of it
Great.
And talk to you about it. But when we hear a story like this, we think about this disease from both a clinical perspective and a research perspective. So
Absolutely.
What you said to us means a lot of things as doctors, and we would have a lot of questions there. But you also gave us some clues as researchers about what may be causing your specific form of vasculitis. So if we brought you to the NIH to evaluate you, we would be thinking about both of those alongside of each other. So for example, from the research side, we'll go there first.
Right.
You said you had a bicuspid aortic valve,
Right.
and that to us is a clue that we don't think you had two very rare things that happened simultaneously and you were unlucky. We think it's more likely that those things are related, and that's giving us clues as to what's causing the problems. And we have some experience with patients with Takayasu's arteritis who have bicuspid aortic valves. Not all of them do, a very few of them do, but they have an incredible amount to teach us. And one of the nice luxuries that we have is we see, around 100 patients with Takayasu's arteritis in our cohort at the NIH. So when we're able to look at the disease in those kind of numbers, we can start to notice patterns. Most physicians, like you mentioned, maybe they've seen 2 or 3 cases of Takayasu. So whatever they see, that's kind of what they know and think about the disease. But if you start seeing 10, 20, 30, 40 patients, you'll notice, as Dr. Quinn pointed out, that patients can be very different from one another, yet even within that, there are patterns. So we would explore the bicuspid aortic valve purely from a research side, and we would think about what is that teaching us? Can we use that information to learn what's causing vasculitis for you? Because we think that what causes Takayasu's arteritis in one patient is likely going to be very different from what causes it in another patient. That's why it's a tricky study. But from the clinical side, you gave us a lot to work with. So you said you were extremely fatigued. This is super common in all forms of vasculitis. I'm sure anybody with vasculitis that's listening to this is nodding their head, whether they have Takayasu's arteritis, ANCA-associated vasculitis, or whatever, because that's a very common symptom of the disease. And it's also an incredibly difficult one for doctors because it's not specific. Many diseases make you feel tired. Many things make you feel tired. And so patients can go around feeling extremely fatigued for months to years before their diagnosis is made because that's just such a non-specific symptom that's hard to nail down. But you ended up having pain in your neck that they thought originally was from your throat and swallowing. Did they eventually think that was pain from your carotid arteries themselves?
No one ever, that's a great question. No one ever circled back to that specifically because at that time in 2014, when I was diagnosed, the damage there wasn't a lot of damage done to the neck yet. It was mostly focused on the arms and a little narrowing in the neck, but not a lot. But I think, like I said, and I don't know, which you'll maybe talk about this a little bit more, but it was really during those stressful situations where I just know stress in general, it wreaks havoc on the body. And that's when I really noticed it, is the pain and really the narrowing when I think that occurred.
Yeah, I suspect also that we would see a lot of virtual heads nodding from patients with vasculitis because we hear that time and time again, that people feel that stress makes their disease worse and exacerbates their disease. Yep. It's a very common theme among vasculitis and among patients with autoimmune diseases in general. When they did the ultrasound of your neck originally, were they looking specifically at your carotid arteries? Or did they just happen to notice that problem?
No, I was very lucky. They just happened to notice it. Like I said, bless the sonographer and the radiologist who did the read because they saw something that they picked up on it and dove into it and realized that there was some narrowing there.
So this likely resonates with many patients with Takayasu's arteritis because we find that the disease can be detected by an imaging study, not looking for a blood vessel problem, but then they happen to notice it. And we see that more and more, particularly as physicians use imaging more and more frequently. So it's very common for us to get a referral from a patient who had a CAT scan for some other reason, and they just happened to notice that the aorta was enlarged. I think because of that, we're probably detecting more and more cases of Takayasu's arteritis. And I wonder over time if the amount of people in the US with the disease is going up slightly because we're picking it up more with using more imaging tests and seeing things incidentally. Tell me a little bit about your left arm. It is that one, the artery to your left arm is completely blocked?
They are actually both now. Since I originally got diagnosed, they are both gone, I like to call them. But, I'm really hopeful for those collateral arteries that are, hopefully are growing. I don't experience much discomfort anymore. I will say there was a period of time, especially after my right arm kind of really diminished. It was just, I couldn't lay on it for very long periods of time. I couldn't, bend any sort of movement that was cutting off any more blood that already was being cut off, really caused me discomfort, like I said, laying on that side. Now I'm very fortunate that I don't notice it too much. I'll notice if I'm wearing a heavy backpack or, starting kind of here, sometimes I notice that my arms get a little more tired or sore. And with the aneurysm, I have a very small lifting restriction, so I can really only lift a gallon of milk anyway. So maybe that's why I don't notice it as much anymore. But I think collateral arteries and veins are starting to grow, which is good news in my case. So.
And when you had those blockages in the arms and you were symptomatic, what happened when you were in the shower washing your hair? Was that a problem?
Yeah, absolutely. Any sort of upward, I have curly hair naturally, but so anytime I was styling my hair any other way, I would just have to put my arm down, and it's just like, it's an exhaustion that, a person without Takayasu or without that blockage, they might experience that after long periods of time of their arms being in the air or, being exerted. But for me, it was a matter of, seconds, where it would be under 10 seconds and I'd have to put my arm down. And then that causes a pain just from it being, it's almost like a soreness pain is the best way I can describe it.
And when you put your arm down, how quickly did that symptom go away?
It would go away fairly quickly, but it's not like, then I'd put it right back up and it would be there again. So the pain would go away, but then it would just be right back to, the second I picked it back up, it was right there again.
So in medical terms, we call this claudication, right? And what that means is you're using your arteries you're using your arms, and the muscles in your arms need blood. And if you use your arms more and repetitively and very active, they need more and more blood. And if the arteries to the arms are narrowed, then you can't get the blood there fast enough when you're doing a lot of exertional activity. And particularly holding your arms above your head requires a lot of blood flow against gravity to your muscles of your arms. So it's really common for patients with Takayasu's arteritis, if they have arm involvement, to when they wash their hair, to get numb, discomfort in their hands, in their forearms, or even in the upper part of their arms, that immediately or pretty quickly improves with rest. Once you stop doing that activity, the blood flow can go through there.
And I don't know if you've seen this then too. So then we run into the issue of, especially with my heart, I have to, and I'm sure a lot of your patients do as well, have to take their blood pressure pretty frequently. So now we're relying on my legs for the blood pressure, which poses a whole nother problem of, you have to be laying down. And so it's just been a very interesting kind of situation to be a part of, especially for, areas that I wasn't even aware that it would affect, not just the movement piece, but other areas as well.
And as Dr. Quinn mentioned, not every patient with Takayasu's arteritis has the same arteries affected. So some patients will have these arm symptoms and this will mean a lot to them. And other patients say, I don't really have that symptom. That's not a problem for me. But the challenging part from the doctor side is the narrowing in your arms could be somewhat permanent, even though it can improve with developing collaterals. So you may always have some limitations in using your arms. Fortunately, when you develop those collaterals, the limitations get less. And just like you said, you weren't able to use them very much, but now over time, slowly things have gotten a little bit better. That's probably from forming better circulation. But I suspect if we made you do repetitive overarm activity for a while, those symptoms would come back.
Yes.
And so Dr. Quinn's point is that the symptom, while the arteries are inflamed and it's narrowing, you could have discomfort in your arms. That's from active disease, from inflammation that we need to treat and get rid of and make you better. But you can be left with damage and you can get the exact same kind of symptoms, even though the disease is no longer active. And those we wouldn't treat with medications. That's why the disease is very confusing to patients and tricky to understand for some doctors. The exact same symptom, sometimes we would treat it if we thought it was active disease, but sometimes we wouldn't treat it if we thought it was damage. And that's where doing the imaging test that Dr. Quinn talked about can be helpful as another piece of information to help physicians make a decision. Is this a symptom I need to treat, or is this a damaged symptom? It's why this disease is incredibly complex.
Absolutely.
And then you had surgery.
I did. Yep.
And the surgery went very well.
I was very lucky. Yes, it was 11 hours long because they didn't know if they could graft off of my aortic arch because of the damage that had been done. So I had my cardiac surgeon. He went in first to double check everything. Everything checked out that they were able to graft off right now. Obviously, that'll change in the future. We'll have to figure that out at that time. And then I like to imagine that they like high-fived. I high-fived as he was going out and my other surgeon was coming in. And then she took over and she performed. So I have the scars there. I've got them on both sides. She performed the carotid artery bypass surgery. Unfortunately, there was a situation where, and she said it was her doing. She was trying to save me a little bit of a scar. I did have to go back a few days later. We noticed some complications. I hadn't lost the water weight from surgery. They were having issues getting a PICC line in my arm, and it turns out that one of the grafts had actually already failed. It had gotten blocked. And so they did go back in, much shorter surgery. It was only about an hour and a half, that one, and they fixed it. But yes, as far as I'm concerned right now, everything it was a success, and I feel very fortunate to have a lot more blood flow, because I actually I did die on the table during surgery. That's how touchy my arteries were. They did several papers afterwards, research papers about how they put me out. I forget the word slipping my mind right now, but how they put me under, because it was just my neck was so touchy that actually during surgery I had gone out for a short period of time. So I feel very lucky.
We keep monitoring sometimes a little bit some of the social media groups with Takayasu, and I hear people referring to yourselves as warriors, and usually that is the case, as you casually mentioned that you died for a second and then soldiered on.
Do what you can, right?
One of the reasons why Dr. Quinn mentioned that we worry a little about surgery and we only do it in certain extreme situations is because of the issues that you had. Sometimes the surgery is unsuccessful, the grafts can fail, you have to go back in. So we try to do this very carefully in a planned way and only for people that really need it. But it sounds like you were one of those situations that she talked about where you had such damage to your neck arteries that they had to go in and do it. So I'm glad things went well.
Thank you. Yeah. And it's one of those things, they do continue to monitor it. To your point, the worry is, or the concern for future, of course, is that the areas where it's grafted onto, those areas can still have inflammation. And if that happens, those areas can then be closed off. And so they do actively monitor me pretty closely for those situations.
And I think that's my last question for you is how do they monitor your disease? How do they know if the disease is active or not?
Excellent. Yeah. So a number of ways, and Dr. Quinn touched on a few of them. And so I do get monthly infusion. So I am on a monthly infusion as far as medication, but that's the only medication that I'm on outside of I have to take a baby aspirin due to having the surgery that I did. So monthly basis, they do blood work. That's just more of a baseline for them to see, well, is the drug helping like it should? If there is elevated numbers, that's just a quick indicator, a very quick indicator, right? Without doing any imaging, that maybe something is going on. But on an annual basis, I do head down to Mayo Clinic in Rochester, Minnesota, and we do a number of studies, whether it's my heart or my head and neck, whether that be an MRA. I've had several MRAs. CT scans are just quick scans to check kind of everything out from here up. I would say those are probably the major ones that they monitor and kind of just compare to past, imaging results and to make sure nothing has changed from that perspective.
Excellent. Well, thank you very much for sharing your story.
Yes, absolutely.
We'd love to have you come to the NIH and
I would love to ask, for patients who I've looked into it, obviously not being in the same state, I would love to learn a little bit more how patients like myself, maybe who aren't located near you, if we can get involved, or if there is opportunities to come visit and be involved from like a shorter period of time. If you wouldn't mind talking about that, I would greatly appreciate that.
Dr. Quinn, you want to take that one?
Yeah, so we are interested in seeing any patient with a diagnosis of Takayasu's arteritis or concern for Takayasu's arteritis. And some people that we see are local, some people are from all over the country or even different countries. So we're pretty flexible with how frequently we see people. Some people will come just one time, some people come more regularly every 6 months or every year. But when patients come to the NIH, We evaluate them in clinic the way your doctors do back home. We do blood work, both for clinical testing and also for research testing that we can talk about in a moment. And then we typically do imaging studies, some which it sounds like you've had before, MRAs or CTAs, but we also do PET scans for research purposes. I'm not sure if you've ever had a PET scan done.
I have.
Some of our patients have had them on the outside, some have not, but we usually do a thorough imaging evaluation and clinical evaluation, and then also try to learn more for research purposes. Dr. Grayson, do you want to talk about the research testing?
The way we see ourselves is a resource. We're a resource to the patients, and we're a resource to their local doctors. And we don't take over care of a patient. We work with their local physicians and we support them when needed. Some patients come to us from areas where they don't have access to an expert in Takayasu's arteritis, which is a large area of the country, unfortunately.
Yeah.
And we can serve as an additional set of eyes, and we are available by phone, by email, by however you want to, get in touch with us. After we've evaluated you, we kind of remain involved to be helpful to you and to your doctors if need be. We also get patients that come from expert centers because we have technology and resources that aren't readily available. As Dr. Quinn mentioned, we use PET scans, and we have designed a comprehensive imaging protocol that's standardized. So we do certain imaging sequences that are not readily available at most hospitals. We try to do this in a way that is complementary to your ongoing management. So we wouldn't do research studies necessarily, or imaging studies necessarily purely for research. We're trying to maximize value. So we would try to time your visit and your imaging studies. Maybe if you're due for a year, your annual imaging, we would do it at the NIH, share those images back with your local doctors so that we're kind of fulfilling two purposes. One is we use those images for research, but the second time is they can be useful for clinical care as well. And from a research side, we want to understand what causes this disease and we want to cure it. I mean, that's the short and simple what we're trying to do. What that means can look like a lot of different things in different situations. We try to customize what we're doing from a research perspective to the individual patient. Some patients, they have very difficult to treat disease. And again, this disease is very different from one person to the next. The thing that makes us worried is when we like it when patients share their stories and learn from each other, but we're also a little bit worried when one patient tells their story and tries to give advice to another patient when their situation may be very, very different. So, I think patients are a good source of support for each other, but they can also make each other worried about things that aren't necessarily relevant to you in particular. So when we do research on patients, we assess what their clinical needs are. Some patients, they have treatment-resistant disease. No matter what drugs they're given, they can't get off of prednisone, and they just can't get their disease under control. So we use research techniques to try to figure out novel ways to treat the disease in those situations. Other patients, we do genetic studies on. In particular, this disease can start very early in life. We've seen, patients age 2 years of age and older with Takayasu. And the earlier it starts, we think it's possibly more likely that there's a genetic cause driving the disease. So not every patient, the genetics may be causing the disease, but in some it may, and particularly if you have really early onset disease. So we want to see the younger children with Takayasu's arteritis, just like we want to see the 20, 30, 40-year-olds, just like we want to see Takayasu's patients who are 60 and have had the disease for 30 years, because they have a lot to teach us as well. So we really don't have age restrictions. We want to see this disease at all phases of the disease in all age ranges. But from the genetic side, we are looking for mutations or misspellings in your DNA that could be causing the disease, and we're doing this in a very deep way. And that means that patients don't necessarily have to come to the NIH to participate in that portion of what we do for research. So we are able to get consent over the phone or video conference now. And we send a DNA test kit, and you have to take it to your local doctors and have a blood sample drawn. And then we pay for shipping, and the sample comes back to us, to the NIH, and we sequence your DNA. And we're looking for clues in your DNA as to why you had the disease. That is a pure research test. It may
Right.
have no benefit to you clinically, or it may down the road. We'll see. And I think, in doing that and seeing as many patients as we can see, this is the way that we think we're going to figure out what causes Takayasu's arteritis. And we really think the cause is going to be different from one patient to the next.
Great. Thank you so much. That's awesome.
Ed, do you want me to jump back in here now? Start with the questions?
Oh yeah, we've got questions. Yes.
Okay. Okay, so I think that was a lot of really, again, great information. I had no idea how, and I still am not sure I understand completely how Takayasu's gets diagnosed in people, but I did want to ask you a few questions about that. So let's start with this. Can you tell us who typically gets Takayasu's and what the prevalence is of the disease?
Sure, I'll take that one. So it's typically, as Dr. Quinn mentioned, younger women. And the prevalence of the disease means how many people are alive with the disease at any snapshot in time. And prevalence is very dependent on the region of the world. Takayasu's arteritis is much more prevalent in Asian countries for reasons that we don't understand. And it's very prevalent in Japan, very prevalent in India. And oddly enough, in India, for example, the arteries that are affected tend to be different than the arteries that are affected in patients with North America. So when we heard Lauren's story, she's talking about arteries affected in the neck. That's very common for patients from North America, whereas patients in India, it's usually in the abdomen. And the symptoms that those would produce would be very different. In terms of the incidence of Takayasu's, that means how many cases are diagnosed in a year, an annual incidence. It's about 1 in a million. So this disease is definitely a 1 in a million disease. And we estimate, doing back of the envelope calculations that are not exactly scientific, but the best that we can tell, there's probably around 3,000 people alive in the United States currently with this diagnosis.
Wow, truly a rare disease. Is there any reason why Takayasu's does typically affect females? Do you know?
We don't know exactly why Takayasu's arteritis affects females more than males. It's something we see across other autoimmune diseases and rheumatology, that women are affected more often than men, but the specific factors in Takayasu's arteritis that make it more common in females aren't clear, but it suggests maybe there are differences in the immune system between males and females. But I don't think we know exactly why it's more common in females.
Well, maybe that research is going to guide you in that direction. We'll hope so. Do you, I think you touched on this a little bit, but is the damage to the heart and the arteries from Takayasu's, is it permanent?
I could take that one. We don't think that we think the arteries, once they are damaged, they never fully go back to normal. But that being said, we do see improvement in arteries when we do serial imaging for a period of time. So in people who are getting imaging studies over a number of years, we do sometimes see that the arteries improve over time. And as I mentioned earlier, new collateral arteries can also form over time around the areas of damage to increase blood flow.
Okay, and I also was wondering this, and this sort of also is something that comes up all the time in my form of vasculitis, but do you recommend that patients with Takayasu's have a team of doctors or one specialty doctor?
I think what you heard from Lauren's story is even within the surgery, there were a team of doctors helping take care of her and passing off from one to the next and high-fiving, or at least imagining that they're high-fiving. I think it's for most forms of vasculitis, these are diseases that cause problems in different spots of the body because you got blood vessels throughout your body. And usually that means that you need a larger group of doctors helping you as appropriate. So with Takayasu's, if you have narrowing in the arteries to your kidneys, you may need a kidney doctor. If you have narrowing in the arteries to your heart, you may need a cardiologist or a heart doctor. If you have narrowing in the arteries of your neck, you may need a neurologist, and you may need a vascular surgeon. So I definitely believe that it can take a village to care for patients with these complicated diseases. That being said, we always recommend that every patient with vasculitis should have a point person, a physician who's really primarily in charge in directing their care and coordinating all these different doctors, making sure that everybody's communicating with each other, which can be very challenging for doctors to do. And whether that's a rheumatologist, a primary care, whomever it is, it doesn't really matter, as long as you as a patient know if something happens and I need to get somebody quickly, this is the doctor that takes care of me. This is the doctor that I call. If there's an issue, that we have a plan in place for how I can get in touch with that person, and that person can help, quarterback and coordinate all my care. So you need a team of doctors, and you really do need that point person.
Great advice. I was going to ask this similar, a question that the whole time you were talking, I was thinking about this. It seems like early detection of Takayasu's is very important. Are there ever any red flags or a cluster of symptoms that could help tip off a general physician that it could be something like Takayasu's that they otherwise might not be looking for? I mean, it sounded like just because of the other things that happened to Lauren that they found the Takayasu's. So how do we help physicians?
Caitlin, you want to take this one?
Yeah, I think it's tricky because people can present in all different ways and have all different types of symptoms. We often meet people after they've been diagnosed and are always interested to hear what that journey to diagnosis was like, as Lauren was sharing a bit about hers. Some people may have no symptoms at all, and even in those cases, there may be a history where for years their doctors couldn't get a blood pressure in their arms or couldn't get a pulse in their wrist, and that was never really further evaluated. Everyone would just go to the other arm and not think any more about it. So that's something we commonly hear from patients, that maybe there were signs that are often overlooked. I think one symptom that's often overlooked that we talked a bit about is that arm claudication, with the arteries supplying blood flow to the arms can become narrowed. And so as the arm is being used, it can become more and more painful and heavy, and then stop once you stop movement, things like washing your hair in the shower. But that's something that often goes overlooked and isn't really further evaluated, and nobody may realize that it's due to narrowing of the arteries of the arm. So that's one symptom we often hear from patients, has gone on for a number of years, sometimes before diagnosis.
Yeah, I mean, one of the challenging things is when we meet a patient, we try to figure out, when did this disease start? And for many patients with Takayasu's arteritis, it's not clear. And it's likely that the disease has been going on for a long time, and the patient may or may not even have known that or had symptoms related to it. If the patient doesn't even know that the disease is there for a long time, it's even harder for the doctor. So you can imagine these scenarios that are quite challenging. I think, as we mentioned, sometimes we're seeing patients that are getting diagnosed incidentally because they had an imaging test and it just happened to turn up an arterial abnormality. Sometimes we see a really good physician take an exam and notice these blood pressure problems or pulse problems. And as Dr. Quinn mentioned, rather than just going to the other arm and ignoring it, they actually follow up on it. These are really important things, but really it speaks to the idea that we need better awareness about this disease among general practitioners. If you have a younger person who's complaining of a symptom that could be vascular, you have to think about this disease. And the challenging thing is it's a 1 in a million disease. So while most doctors could be trained to think about it, they likely will never see it.
So complicated. Again, just like so many forms of vasculitis are. The answers are never very clear, are they?
But we can still make progress and improve.
And absolutely, and that's what your research is for, and we're very appreciative of it. Well, I would like to thank you all for being part of this webinar today. There's so much information that will help the patients that are already living with Takayasu's. I'm sure, as Lauren said multiple times, this is the kind of thing that we need our doctors to do so that we have these kind of webinars and can learn more about it. So we greatly appreciate your time for this.
And our program is open to anybody from any part of the world. We want to be involved. We want to help. So just reach out.
Lauren, did you have any other questions before we end today?
You touched on a lot of the questions that I had. I'm just looking at my list. So I think all of mine were pretty much answered in one way, one form or another. I think the only thing, if you could just speak on to it a little bit more, how can patients help spread awareness? Obviously there's a small group of us. So, what other ways do you feel would be beneficial to help spread awareness?
I think one thing that's really important and that I've seen the Vasculitis Foundation do a great job of is sort of the buddy system. And, this is a disease that often happens to young people, particularly teenagers. And that's a really vulnerable time in life. And it's a scary disease. And as you know, you get a lot of prednisone with this disease that comes with its whole baggage and issues. So rather than necessarily educating the general community about the disease, which is challenging, I think the most impactful thing a patient with Takayasu's can do is share their stories with people who are newly diagnosed. People, so that, if you've been through this, the process, what's on the other side. To be a support to patients that are newly diagnosed is so invaluable, and it's so much more powerful than even, physician intervention in those cases.
Awesome.
Some really great advice. We appreciate that. Again, I want to thank Lauren, Dr. Grayson, and Dr. Quinn so much for your time today and explaining Takayasu's to our community. And we will take your advice and help each other, support each other in this, and talk more about it with the newly diagnosed patients. I'd also like to especially thank our sponsors, ChemoCentrix, Genentech, and Amgen, for the support of our Road to Wellness webinar series. They're helping the Vasculitis Foundation provide these valuable educational webinars and support our commitment to patient education. And also this year, watch for more disease-specific webinars like this one that we did today. The plan is to have one on every form of vasculitis before we're done. We appreciate everything that you all do for us in your research and for your time and work with us today.